Continuing on with our soft tissue injuries, we move into burns. Now, burns, we think about chemical, electrical, and thermal. Just understand that these can cause either coagulative or liquefactive if we're looking at some kind of acidic or alkaline voltage. As far as electrical burns, will cause some of blast type injuries where the electrical impulse has to be grounded. So look for entrance and exits on the blast. And then as far as our thermal burns, look at the zones. We categorize these zones as first, second, and third degree. First degree being superficial, second degree partial thickness with some blistering, possibly open blistering, and third we got full thickness going down through the skin layers, down into the tissue areas, and it's quite deep. We do talk about our zone of coagulation, zone of stasis, or ischemia. Body surface area, we use the rule of nines. Pediatric rules tend to change, but the idea is we also use the rule of palm. We'll be using the body surface area to treat these patients, so we need to identify our body surface area. Moderate burns. Moderate burns are burns about 15 to 20%, 25% total body surface area in adults, 10 to 20% in children or elderly. These may be full thickness, 10 to 20%, 2 to 10% total body surface area. As long as they're not complicated by inhalation injuries, complicated by trauma, or complicated by high risk or immunocompressed or some compromised. Severe burns are anything greater than 25% in adults, 10% in younger children. That's total body surface area. And these are also areas of the face, hands, feet, perineum, chemical burns, high voltage burns. And then if they are complicated by respiratory compromise, complicated by trauma, these all are severe burns. I mentioned prior that we may have a total circumferential burn. This total circumferential burn will cause that burn site to become very edematous. That edema will cause a lot of pressure. That burn, tough, edematous skin, that scar, will cause the underlying muscle and tissues to become ischemic because of that compression. And so we would think about trying to decrease that compression. They may end up making an incision to release that pressure to allow more blood flow to that area. Now, secondary to the burn, we worry about infection and sepsis. As we know, the skin is the first line of defense. It's our external defense mechanism. When that layer is damaged, it allows foreign invaders, non-self, to enter our body and then into the bloodstream, and this will cause the compromise of our burn patients. So we want to maintain sterility, and when we think about it, we really want to make sure that not only the dressings, but our gurneys, our gloves, anything that we're touching them with after having removed them from the scene and started to undress them, that we want to try to minimize any further contamination. Now talk a little bit more about focus in on hydrofluoric acid burns. Hydrofluoric acid used in glass etching. These cause significant burns. We would look at the patient resulting from hypocalcemia. So we would actually use calcium in this case as a treatment. You'd look for tetany in the upper extremities in the hands, as well as tetany in the cheek area. Look for calcium gluconate as part of our treatment. And we'd also use this calcium in a slurry or type paste over the type of wound so that it can draw the chemical. Other burns may cause respiratory compromise or respiratory issues. We need to be aware of those. I'd like you to continue on to look over phenol, phosphorus, lime, and all these other types of chemicals that can cause chemical type injuries. We'll move on to electrical injuries. The electrical injuries, remember I told you that we're looking at an internal source, entry source of electricity, and then it has to ground itself, so it'll have some type of blast or exiting injury. This electrical impulse will travel across the myocardium, causing the person to go into ventricular fibrillation. All the other muscles become very tetanized, and we look at causing significant muscle damage, causing myoglobin to be leaked out into the bloodstream, and we can see this affecting the kidneys as well. This may also cause blood vessel and nerve damage. Lightning strikes, we would be looking at, and I guess the buzzword here is we look for ferning on the skin. It looks like it's a fern-like pattern after being struck by lightning. Again, we're looking for or being cautious about our myocardium, and so we should be monitoring them on the EKG. So let's go over rule of nines right now. So the rule of nines, the adult has nine or 11 9 areas. So if you can break that all down, 9 to the head, 9 to the upper chest, 9 across the other chest, 9 across the belly, 9 across the other belly, 9 for each leg, arm, 9 for each arm, 9 for each leg, 9 for each leg, another leg. So as we think about it, it's 11 nines. I give you 99, and then the 1. You guys guess where that 1 is. And then look over your pediatric setting. In the pediatric setting, 18 is for the head, 18 is for the back and front, and then they break the extremity up into 13 and a half. Remember, we look at the we look at the palmar surface of your patient being 1% body surface area, and we were calculating significant body surface area. We're looking at second and third degree. Again, we are not using first degree burns to calculate our body surface area. When we use our treatment as far as fluid resuscitation, we're looking at about 2 to 4 cc's per kilogram per total body surface area. A max would be 4 cc's per kilogram per body surface area. And that entire volume, half of it is given over the first 8 hours. So a lot of times we were very short in giving any fluid and resuscitation in the field. So we were way behind that 8 ball. What we want to do is try to disperse this fluid boluses over that whole 24-hour period. And so the first half of that bolus, that total bolus, 4 cc's per kilo per body surface area, is given over the first 8 hours. The second half is given over the next 16 hours. All right, and then we'll calculate the range based on the further range of 2 to 4 cc's and relative over the next days of fluid resuscitation. But we're looking at least the first. So the idea here is that we need to give a lot more fluid. As we're treating our patients with fluids, we're also managing their airway, because burns, we think about thermal burns, caustic burns, we think about inhalation burns, we think about acoustic poisonous toxins that they've inhaled. This may cause inhalation injuries, and once the inner line of the upper airway becomes swollen, we're not going to be able to get a direct path to ventilate or oxygenate our patients. That being said, these type of chemical and inhalation injuries can also cause damage to bronchioles and alveolar areas, causing a shunting of oxygen and blood supply going back and forth. So our oxygen is not getting to our red blood cells that are dependent upon it to circulate throughout the rest of the body. Some of our interventions then is to provide high flow oxygen, knowing that even in our burn settings, that even though they may have 100% on the oxygen saturation, this may be erroneous because of carbon monoxide likes to hang on to that. Now, other products of combustion may also be cyanide, and these things all work on our oxygen getting into the bloodstream. This decreases the oxygen capability to get to the blood cell, or the blood cell to absorb the oxygen. So oxygen, ventilate when we need, and if we are concerned that the airway may be closed off or swollen in later on down because of the type of injuries due to inhalation burns or burns themselves, then we want to manage their airway ahead of time and be proactive so we can take care of that airway now rather than later making it a problematic airway. Now we want to get them to our treatment center. The most appropriate would be a burn center. We don't have one of those on the neighbor islands. So in the time being, we want to make sure that we keep them aseptic, provide them with high concentrations of oxygen, manage their airways appropriately, provide them with fluids, tank them up a little bit, and we want to also give them pain management, narcotic analgesics for the pain, 5 to 10 milligrams morphine. Look for vasodilation and histamine release. You may decide to go with I'm trying the other narcotic that we use. You guys got the answer for that. All right, we'll pick up where we left off.